The Walk in Our Shoes report was commissioned by the National Stroke Foundation in 2006 to assess the attitudes, knowledge, behaviour and needs of stroke survivors and their carers. The NSF used interviews and surveys to find out how stroke had impacted on their lives, what post-stroke support they needed, and in particular, what would make a difference. In 2008, the NSF employed consultants to develop a national stroke strategy that recommended the establishment of stroke liaison officers to help stroke survivors and their carers to transition from the hospital system to the community care system. However, from the point of view of stroke survivors and carers living in Australian communities, we have seen negligible improvement in the availability of community support to stroke survivors and their carers, many of whom are still wallowing in our individual black holes. In the words of that venerable physics educator, Professor Sumner Miller, why is it so? Finally, what support do we need from stakeholders in the current failing system for this to happen? The first thing is for the National Stroke Foundation and Stroke Association of Victoria to endorse this consumer-initiated community care approach. We also need clinic-based GPs to accept that this is a much more sensible approach to providing community-based stroke support than the current system, and to refer their stroke patients to community health centres with embedded stroke consumer consultants. We also need subacute care hospitals to endorse this approach to the provision of long-term community stroke care, and to eventually agree to refer all stroke survivors to community health centres. Then there are state-based stroke associations in most Australian states. But these organisations face even more severe problems than NSF with the way they are funded and the way they rely on volunteers rather than full-time staff, and the lack of staff who have credibility with medical professionals and hospitals. This means they are unable to get access to information about stroke survivors when they are discharged from hospital. This information is absolutely essential for an organisation that wishes to take responsibility for managing the community care stage of individual stroke survivors and carers. So, state stroke associations cannot provide effective long-term chronic care at the community level either. Ideally, the state stroke associations should focus their limited resources on supporting the operation of community-based stroke support groups, setting up new stroke support groups, the training of stroke support group leaders, and promoting information exchange and contacts between stroke support group members. So, who is us? Based on statistics published by the National Stroke Foundation, in each year 60,000 Australians suffer a stroke, which is 0.26% of the Australian population, and 72% of these are having their first ever strokes, while 28% are having recurrent strokes. About 20% of people die within a month of having a stroke, and 33% live longer than 1 year after their stroke. About 88% of stroke survivors live at home, most with a disability. Using these figures, one can conclude that each year there are about 35,300 additional stroke survivors being discharged to live at home in their communities. And if we accept that there are 350,000 stroke survivors currently living in Australia, there are about 35,000 stroke survivors, or about 10% of the total number of stroke survivors, or 0.15% of the Australian population, who are less than 12 months post-stroke and are either still in hospital or newly discharged to their homes. Let us assume that all these people are still dependent on clinical support from their stroke teams and can therefore be classified as being in the clinical phase of their stroke recovery. If this is accepted, then there are about 315,000 stroke survivors, or about 90% of the total number of stroke survivors, or 1.37% of the total Australian population, who are greater than 12 months post-stroke and are now living in their communities. But if we then assume that all these people are no longer dependent on clinical support, or no longer in regular contact with their acute or subacute stroke teams, they can be classified as being in the post-clinical phase of their stroke recovery. So, just 10% of us can be considered to be still in the clinical phase of our stroke recovery, while 90% of us have moved on into what can be called the post-clinical phase of our stroke recovery. These statistics can be summarised in this figure. It shows a timeline which starts at the time of the stroke and admission into an acute care hospital, followed by transfer to a subacute hospital and eventually to discharge to live at home in the community. Over this time, we see how the focus gradually changes from a purely clinical focus to a purely post-clinical focus, or chronic focus. If we draw an arbitrary line at, say, 12 months post a stroke, we can see that there are about 35,000 stroke survivors, or 10% of the total stroke survivor population, who are on the clinical phase side of that line, while there are about 315,000 stroke survivors, or 90% of the stroke survivor population, and 1.37% of the total Australian population, who are on the post-clinical side of that line. This illustrates very clearly that while the first 12 months post-stroke is critical from a clinical point of view, that focus gradually changes to the point where stroke survivors and their carers enter the post-clinical phase of their stroke recovery, which is largely dependent on community care. So let's look at how the major stakeholders in the stroke industry are serving these two groups, namely the stroke survivors still in the clinical phase of their stroke recovery and those in the post-clinical phase of their stroke recovery. First, let's look at the acute and subacute hospitals in Australia, which are responsible for the acute care and subacute care stages of this continuing care pathway for stroke. Despite the enormous pressure on public hospitals to handle an increasing number of strokes in an ageing population, the hospitals generally provide amazing services to people who suffer strokes, and they are getting better and better at saving lives and restoring basic functionality to stroke survivors. But the focus of hospitals must be on the acute and subacute stages of the stroke recovery journey. They cannot be expected to support stroke survivors and carers indefinitely, and must discharge stroke survivors to the community care system and to their eventual fate of having to navigate this highly fragmented system for the services they need. Hospitals simply do not have the financial or skilled human resources to provide long-term community care. They can only ever be effective players in the acute and subacute stages of our stroke recovery journeys, and for that we must always recognise the debt we owe them. We now come to the community care stage of the continuing care pathway for stroke, where we switch from the relatively short-term reliance on acute and subacute services to a very long-term, in fact a lifelong reliance on post-clinical or chronic care services. In the current system, the community care stage relies very heavily on the clinic-based and clinically trained general practitioners. This clinic and clinical focus, as opposed to a whole of community or post-clinical focus, is the first of many structural problems we face, because different stroke survivors in a given community will receive different standards of primary health care depending on the stroke-related knowledge, skill and experience of the practitioners in their local medical clinics. Most GPs receive only superficial training in neuroscience and lack both the knowledge and experience to take care of people with complex stroke-related physical, mental, psychological, mobility, social and communication disabilities. Specifically, they lack the knowledge and experience to understand the interaction between stroke-related disabilities and the psychological problems those disabilities generate. The Medicare funding model that applies to general practice discourages GPs from spending the time and effort needed to address the wide range of problems that stroke survivors might present, and which change significantly over time. And often, access to appropriate medical services are available only to strokies with private health insurance. That funding model also discourages GPs from spending the time and effort to develop and manage long-term care plans for all but the most disabled stroke survivors. For many survivors and carers, the role of GPs is limited to preventing further strokes by prescribing blood pressure, cholesterol, and blood thinning drugs as appropriate. They must rely on referring survivors to other medical professionals to address chronic stroke-related disabilities. As an illustration of the inability of general practice to deal with the complexities of the stroke recovery process, we can look at this cognitive screening test used by GPs in their clinics today. The first point to make is that this screening test was developed by the Dementia Collaborative Research Centre, not the Stroke Collaborative Research Centre, or even the National Stroke Foundation. It is one of the standard protocols used in general practice in Australia today to identify people with dementia, and obviously designed to be conducted within the time constraints of a standard Medicare-funded consultation. But do we need to point out that stroke survivors do not have dementia? We have had strokes. So this sort of screening test is totally inadequate for assessing the cognitive and mental deficits that need to be addressed as stroke survivors embark on their long stroke recovery journeys in their own communities. So, where is the comprehensive screening test that can be used to plan and monitor the progress of stroke survivors and their carers in their communities? The next major stakeholder is the National Stroke Foundation, which is the national body responsible for stroke in Australia. Over the past few years, the National Stroke Foundation has been doing an excellent job in the areas of acute and subacute care, with the development of updated clinical standards and guidelines, and promoting the development of stroke units in key hospitals in Australia. The NSF has also played a key role in the community care area by promoting stroke awareness and stroke prevention messages within Australian communities. But the focus of NSF has been almost exclusively in the clinical phase rather than the post-clinical phase of stroke recovery, where up to 90% of stroke survivors and their carers in Australia find themselves. For the majority of stroke survivors and carers, getting access to appropriate post-clinical support in their local communities is critical. But the issue of continuing community care is extremely difficult for the NSF to tackle, partly because of the way it is funded and the way staff is employed on short-term, project-oriented contracts. Organisations that are structured and funded like the NSF simply cannot provide long-term chronic care to the post-clinical stroke survivors and carers living in their communities. What stroke survivors and their carers, and the Australian community in general, needs is for the NSF to focus its limited resources on continual improvement in the acute care and subacute care sectors, that is, the clinical phase of stroke recovery, and to delegate the responsibility for long-term chronic care, that is, the post-clinical phase of stroke recovery, to organisations which have much better links to the Australian communities where stroke survivors and their carers live. Then there are state-based stroke associations in most Australian states. But these organisations face even more severe problems than NSF with the way they are funded and the way they rely on volunteers rather than full-time staff, and the lack of staff who have credibility with medical professionals and hospitals. This means they are unable to get access to information about stroke survivors when they are discharged from hospital. This information is absolutely essential for an organisation that wishes to take responsibility for managing the community care stage of individual stroke survivors and carers. So, state stroke associations cannot provide effective long-term chronic care at the community level either. Ideally, the state stroke associations should focus their limited resources on supporting the operation of community-based stroke support groups, setting up new stroke support groups, the training of stroke support group leaders, and promoting information exchange and contacts between stroke support group members. We now turn our attention to stroke support groups. Even more than the national or state stroke associations, these stroke support groups face even more severe problems in getting access to a reliable source of funds and have to rely almost exclusively on dedicated members who are either stroke survivors themselves or their carers. So the issues of financial and human resources and continuity are a constant threat to the survival of these groups. Most stroke support groups lack staff and leaders who have any credibility with medical professionals or hospitals, and this severely limits their capacity to provide continuing community care. and stroke support groups are unable to get access to information about stroke survivors living in their neighbourhood once they are discharged from hospital. So stroke survivors and carers often do not know about the existence of a stroke support group in their own town or suburb. So stroke support groups are unable to do anything for anyone other than their members, and these represent just a small percentage of the stroke survivors and carers living in their community. Instead, they must focus on supporting the community care needs of their members, providing stroke-related information and encouragement to their members, improving the quality of life of members, and helping them to rebuild their personal, family, social and community involvements. Sadly, for the majority of stroke survivors and carers in the community, stroke support groups are ineffective because they don't know they exist or what help they can provide. Finally, we have ourselves, our fellow stroke survivors and carers. How do we possibly continue to fail ourselves? Most of us engage in a constant search for information about stroke recovery and the services that help us get on with our post-stroke lives. Often that information is available on the internet, but many stroke survivors and carers do not feel comfortable using computers to gain access to that information. Instead, we rely far too much on medical professionals to tell us how we should live our post-stroke lives. And although those medical professionals are undoubtedly experts on medical matters, most have no idea about how a stroke affects the interplay of temporary or permanent physical disabilities and the emotional problems they cause. Only stroke survivors and their carers can experience the effects of this complex and continually evolving interaction and the impacts they have on their quality of life. Only we know what priorities need to be placed on our post-stroke recovery to maximise our quality of life. But most stroke survivors and carers feel utterly powerless in moulding the current system to address our particular long-term community care needs. And sadly, there is no organisation that can advocate for us to change the current system from one that is dominated by issues related to acute care and subacute care to one that focuses on continuing community care. So, if the current community care system consistently fails us, what can be done to change that situation? One way is to identify an ally in the community health system which has common interests with stroke survivors and carers, and to convince them to play a major role in the stroke community care system. So, what are the characteristics of such a potential ally? A potential ally must have access to multiple reliable sources of funds including federal, state and local governments, as well as philanthropic and charitable institutions. It must have access to stroke-related knowledge and skills, particularly in the areas of allied health. It must have credibility with the medical profession so that hospitals feel comfortable in passing on the details of stroke survivors discharged into their communities. It must have a proven track record of providing community health services. It must have a commitment and preferably an incentive to keeping people out of the hospital system. And it must have a commitment to improving the quality of life of members of the communities they serve. One such potential ally, at least in the state of Victoria, is the local community health centre. There are 100 community health centres currently operating within Victorian communities. They offer a wide range of primary health and community services, such as allied health, chronic disease management, and support for self-management, disability services, health promotion, exercise physiology, and mental health services. Their staff typically includes general practitioners, allied health professionals, nurses, and business managers. They have reliable access to multiple sources of funds within local, state, and federal governments. And they exist, as stated on the Department of Health website, to intervene early to maximise health and well-being outcomes and prevent or slow the progression of ill health. In other words, they exist to keep stroke survivors and their carers out of hospital and to improve their quality of life. So, there is a very real basis for developing a strong, long-term relationship between stroke survivors and their carers and their local community health centre. That relationship is based on a common interest or need to keep stroke survivors and their carers out of hospital, to improve the quality of life of stroke survivors and carers, to promote the practice of self-management by stroke survivors and carers, and to get stroke survivors and carers connected to appropriate community and health services, including connecting stroke survivors and carers to their local peer support groups, if appropriate. So, what do we mean when we talk about our quality of life? In the medical context, the term quality of life refers to an individual's total well-being, including all emotional, social, and physical aspects of the individual's life. The very least any stroke survivor can hope for is to regain an acceptable post-stroke quality of life. As this diagram illustrates, a person's quality of life may drop catastrophically immediately following a big stroke, as physical emotional, mental and communication capabilities rapidly decline. Then, as the acute and subacute professionals get to work, some of that functionality recovers, and the stroke survivor's quality of life slowly returns until the survivor is discharged back into his or her community. But what happens next not only depends on the fighting spirit of the survivor, but on the level of community support the survivor gets in the months and years that follow. Let's consider two possibilities here. In the first case, the survivor has poor community support. That is, limited access to community services to rebuild his or her post-stroke life. What we might expect to happen here is that there is an initial increase in quality of life as the stroke survivor continues to regain functionality. But things eventually become just too hard, and the stroke survivor sinks down into their own big black hole and a lower quality of life. On the other hand, if the survivor has good community support, we might expect a continuing increase in quality of life as the survivor discovers new activities that make use of recovered functionality and provide pleasure and meaning for the remainder of their post-stroke lives. So, in what form should that partnership between the stroke survivor community and the community health centre take? Well, one possibility is for community health centres to create special stroke consumer consultant positions, which are filled by stroke survivors and or carers and play a non-clinical role within the community health centre and has responsibility for all stroke survivors in the community served by that community health centre. The stroke consumer consultant would have close relationships with various community health centre clinics, including general practice clinics and allied health professionals. The community health centre would also offer Medicare funding of services that are critical to the long-term stroke recovery process, including neurophysiotherapists and neuropsychologists who can advise the stroke consumer consultant in planning and monitoring the long-term improvement of the stroke survivor's quality of life. Now, it is important to stress that a stroke survivor or carer must receive appropriate training before taking on the position of a stroke consumer consultant. As we all know, there are many existing Certificate 4 and diploma courses for paramedics who support qualified medical professionals in a variety of ways. My suggestion is that we need a new Certificate 4 or diploma course for stroke consumer consultants. This course would include an appropriate selection of units from existing courses, including ones in mental health, aged care, home and community care, counselling, community services and case management. and supplemented with the number of stroke-specific units. This course would be developed by an appropriate education institution, and it would be delivered as an online course that could be taken by stroke survivors and carers anywhere in Australia. Graduates of these courses could potentially play a role as gatekeepers or pathway coordinators for entry into various community care pathways within a community health organisation. Now let's look in a bit more detail at this stroke consumer consultant position. The first thing to understand that this is a non-clinical role, and the person who fills it will need to be trained in the operation of medical clinics so as to be able to work cooperatively with medical professionals and have basic education in the neuroscience of stroke so that they are well aware of the way a stroke might affect all aspects of a survivor's life. The responsibility of the stroke consumer consultant to stroke survivors and carers should be to provide the long-term monitoring of disabilities that impact on the survivor's quality of life. The linkage of stroke survivors and carers to community and health services that improve that quality of life. The provision of stroke-related information and education to stroke survivors and their carers, and the linkage of stroke survivors and carers to their local stroke support groups. Another important role of the stroke consumer consultant could be to organise regular community stroke forums where stroke survivors and their carers can get access to up-to-date information about stroke recovery from stroke clinicians and research workers, and where they can express their stroke recovery concerns and issues. Learn more about local stroke support groups and local community stroke support services, where stroke research workers and neuroscientists can meet stroke survivors and carers who are the potential beneficiaries of their research and outline the progress and benefits of their work for stroke survivors and carers, and get ideas about future lines of research, where local medical professionals, including GPs and allied health professionals, can get up-to-date information on stroke recovery, meet stroke survivors and carers in an informal environment, and meet the stroke research workers and neuroscientists who develop therapies. And finally, these forums would allow the stroke consumer consultant to build up a register of stroke survivors and carers living in their community. Finally, what support do we need from stakeholders in the current failing system for this to happen? The first thing is for the National Stroke Foundation and Stroke Association of Victoria to endorse this consumer-initiated community care approach. We also need clinic-based GPs to accept that this is a much more sensible approach to providing community-based stroke support than the current system, and to refer their stroke patients to community health centres with embedded stroke consumer consultants. We also need subacute care hospitals to endorse this approach to the provision of long-term community stroke care, and to eventually agree to refer all stroke survivors to community health centres with embedded stroke consumer consultants. And finally, we need federal, state and local governments to commit to funding this initiative and to promote its national rollout to help reduce the ever-increasing direct and indirect health costs associated with stroke.